Now we shall start the clinical cases, very similar to those that will be on Monday. Let's start. I invite you to answer these questions. It is necessary not only to name the syndrome, but to explain why do you think so, and to make the plan of necessary investigations. So,
I think
maybe
it's obstructive
yes.
jaundice.
Please, why do you think so? Answer this question. Why do you think so? Why is it obstructive
Because
jaundice?
of left hypochondrial and epigastric pain. This is the place where the gallbladder is, and after food intake, because like after food intake there is secretion for bile juice, and if he feels pain at the secretion of bile juice, it means that it's obstructed. That's the conclusion.
Okay, David. First of all, it is good that you decide to answer, but tell me, please, where do you think where do you see jaundice here?
Oh, sorry, I thought we were continuing
But
on this
really,
presentation.
really, your logic is absolutely correct. If jaundice is estimated here, you are quite right. Yes. But the jaundice is not estimated here. And have a look. Abdominal palpation reveal tenderness in the left part of epigastric area. So just forget for a minute about jaundice and try to do it once again. It is a chronic situation with an acute above chronic situation. Why is it so? Because the patient has the medical history of alcohol abuse. Yes? And left hypochondrial and epigastric pain. Tell me, please, which organ, which organs are proacted with pains here to this zone, which is indicated?
Spleen.
It is too high to the spleen.
Stomach.
It is partly stomach, duodenal zone, and pancreatic zone. These three organs. But the epigastric pain usually appeared 2 hours after food intake. It is more typical to duodenal and pancreatic involvement, though to stomach. Stomach more earlier, less than 1 hour. At night time, it is also typical for duodenal localization of damage. Irradiation to the back in belt-like pattern. It is typical for pancreatic gland. And damage of external pancreatic activity may be described by diarrhea and losing of 8 kilograms for last 2 years. It is chronic process with chronic intoxication. Nothing is said about liver because it doesn't give us any pain syndrome. And he comes to the doctor only because of pain. According to these clarifications, What would you suspect? Which syndrome or syndromes? It may be duodenitis or gastroduodenitis and pancreatitis. Once again, why is it so? It is so because onset of the pain syndrome 2 hours after food intake and at night time during the starvation. With irradiation like belt, typical to pancreatic gland. Nighttime epigastric pain, more typical to duodenitis. Left localization is also more typical for duodenitis and epigastritis. Oh, pancreatitis, sorry. So uh, we can suspect gastroduodenitis or only duodenitis and pancreatitis. Understanding that it is so, or which investigations are necessary? Please, colleagues, what do you think? Which investigations are necessary? If it is gastroduodenitis, what will help us?
Endoscopy.
Yes, upper endoscopy. If you answer only endoscopy, you will be asked which one. In this case, upper endoscopy. Is it enough? What is about other instrumental tests,
X-ray
investigations?
X-ray maybe.
X-ray. X-ray of what?
of the abdomen
Abdominal. What is it for?
for investigating if there is some masses, maybe,
Common X-ray won't
or
give you enough information. I suppose my surgical colleagues taught you that common X-ray of abdomen is fulfilled in case of bowel paresis, when you do not auscultate bowel murmurs, bowel sounds, or they are so loud that it's better to investigate. And the corresponding X-ray symptom of paretic intestine and bowel will be presented. Do you know about it? I shall try to find during the next break. I shall try to find such X-rays. This is the only purpose for X-ray in emergency. Speaking about computer tomography, it may be, but we need contrast and we need some time to get creatinine result in blood. Without it, we can't perform any contrast investigations. But easier, or we can perform ultrasound of abdominal area. And if we are lucky, if the patient is not obese and not excess gas in the abdominal cavity, we can see pancreatic gland. We can see pancreatic gland, and it will be enough if there are any severe abnormalities. Severe masses we can also see with the help of ultrasound, the gross masses. So ultrasound, and it's better to exclude or to identify ascites, excess gas in abdominal cavity. This will be enough. And then laboratory investigations. What do we need here concerning duodenitis and pancreatitis? Yes, we have forgotten to say that during upper endoscopy, it is good to perform biopsy of mucose for two purposes: Helicobacter papillary investigations, and morphological verification of the type of sputum damage. As we have discussed, it may be any type of gastritis also, and duodenal biopsy if it is necessary. What laboratory investigations here will be suitable? What do you think? Complete blood count. Without any doubts, it will show us the inflammation, and we can suspect or exclude bleeding. Which parameters will show us inflammation? Leukocytes, erythrocyte sedimentation rate. Which parameters will show us possible bleeding or its absence? Hematocrit and erythrocytes. Yes, so CBC. If we speak about possible pancreatitis, which investigation will show us inflammation of pancreatic gland? Which enzyme is it necessary to check in the blood? It is amylase or lipase in urine. And this will be enough. If more intensive investigations are necessary, please don't forget about MRI or CT with contrast for verification of Holy ducts for liver and pancreatic ducts and gallbladder together. All this zone will be checked with the help of the contrast. You will be shown the walls of the ducts, all ducts, and possible interruptions, atresia, stones, any other formations, tumors, and so on. Okay, colleagues, any questions about this case? No? Okay, let's go on. Case number 2, please. So who is ready to answer the questions?
Maybe duodenal ulcer?
It is duodenal problems, but why do you think it is ulcer? Why not duodenitis? We can't estimate either it is duodenitis or duodenal ulcer, yes? But the logic is correct. Is it an acute situation or acute or exacerbation of a chronic one? What do you think?
I think it's chronic.
You're quite right. It is chronic because we have the history of 2 years of such episodes with relapse in autumn and vernal time. It is typical for exacerbations of stomach and duodenal problems, itises or ulcers, either gastritis and duodenitis or peptic ulcer diseases. First question, why is it duodenal zone, not gastric zone? Because of the location Is it estimated? No, it is not estimated because it is 2 hours after food intake. You may suspect it is gastroduodenitis, and nobody will punish you. It will be a correct answer because it is very difficult to separate these two organs. What investigations are necessary?
Endoscopy.
Upper endoscopy with biopsy. Don't forget to add it or you will be asked about it. So gastric zone, duodenal zone must be expected, yes. What else?
Ultrasound
Ultrasound of which zone?
of the epigastric zone.
Abdominal ultrasound, what will you verify here?
Any abnormalities in the like in the wall of the duodenum, maybe.
Maybe, but it must be extra high class ultrasound. More often, it is enough to, well, images are enough from endoscopy. It will, first of all, answer to the question about liver sizes, spleen sizes, about vena porta and the absence of excess amount of gas and the absence of liquor in um, abdominal cavities. Okay,
And blood
laboratory.
test.
Yes, and what?
Blood test. We will
Yes,
check for the count of leukocytes because if it's duodenitis, it means it's inflammation, and inflammation
good.
attacks leukocytes. That's
With
how we
left deviation possible, possible without it. Yes, and we shall notice the level of hematocrit and hemoglobin to be sure that the patient doesn't have bleeding.
bleeding.
Yes, the same as for a cold blood stool test, especially if endoscopy verifies ulcer damage, which is more suitable with bleeding than only duodenitis. Okay, it is good. By the way, 2 hours after food intake and relief by intake of antacids, typical both for gastritis and duodenitis. But 2 hours after food intake, it is more to duodenitis.
Can
Good.
we
Professor,
make
Yes.
like a check for the gastric juice in the blood?
If
If
it is necessary. Nowadays, it is estimated that it is not of high level of diagnostic sense. Mhm.
Professor,
Yes,
can we
yes.
add urea breath tests for the investigation?
Without any doubts, but if you perform uh, endoscopy, you will take all necessary material for Helicobacter test because urea test may be limited because of antacids intake, if you remember. Yes, proton pump blockators and antacids are contraindicated if you'd like to perform the tests for verification of Helicobacter with exhalated gas or in feces. And they are not contraindicated if you will test the material which was taken with the help of biopsy. Mhm. And the last case in this block, please. There are two syndromes here. Look attentively at hemodynamics parameters. It is an acute situation without any doubts. So, colleagues, it's again duodenal zone damage, but the damage is more to peptic ulcer disease. Why? We can see decreasing of blood pressure. It is typical for shock with tachycardia and corresponding dyspnea. It is because of cardiovascular problems. So it is necessary to perform simultaneously upper endoscopy and take complete blood count to see the level of hemoglobin and hematocrit. Very often, 99 percentages that it is gastroenterological bleeding. And because of epigastric pain after food intake in 2.5 hours, it is duodenal zone. So it is an emergency situation, and we can't divide it to surgical and therapeutic one. Sure, it is more close to surgical. Endoscopy will be of diagnostic sense from one hand, and of treating. We can treat with the help of endoscopic procedure the bleeding from the ulcer, and then intravenous corresponding therapy for treating of the ulcer of duodenal zone. Is it clear? Once again, why am I ready to suspect gastroenterological bleeding? Because of low level of blood pressure. All other parameters are because of decreasing of blood pressure. These are compensative mechanisms. Questions?
Okay,
No.
and
Yes.
why after having pain at night time?
At night time, for duodenal ulcers, it is typical to have, so to say, starvation pains. Aggressive factors are more aggressive without food. When food have gone away from the zone of inflammation, they are more aggressive. That's why after food intake, when food comes to the zone of duodenal tube, and then when the tube is empty. It is
So
typical
it's not
for
related with circadian rhythm?
yes, it is because of vagus activation also. Yes.
Okay, thank you.
Mm-hmm. So 5 minutes of resting, I shall try to find you X-ray pictures. So these are the clinical cases you will see at exam on Monday. We decided to send them today. If you have any questions, we shall ask them. We shall answer them tomorrow. I suppose we will be able to solve not less than half of them, maybe about this, but tomorrow we'll have another opportunity to do it. So let's start. The task is indicated, and two standard questions are here. Yes, what would you like to ask?
Can you send for us the cases for today for
Yes,
example?
we shall do it today. I shall
Okay, thank
send
you.
to your leaders and they will resend to you
Okay, thank
without
you.
any doubts.
Thank you.
Once again, please don't share with this material to other groups, only groups 78, 77, 76 are here with these clinical cases because they will have other. It doesn't, it is not necessary to do. The first clinical case, please. I suppose we have done it. Yes, no?
Pneumonia, maybe?
Yes, you may suspect pneumonia. Why do you think so? Which are the main syndromes here?
Sudden onset of chest pain and shortness of breath.
These are
Okay.
sciences. These are sciences.
Yes,
We're speaking
science.
about syndromes. Colleagues, I remind you what syndrome is in comparison with sign. It is a group of sciences. Syndrome is a group of sciences which are connected pathogenetically. We shall discuss it once again tomorrow. But please now be sure that all you have mentioned, these are sciences. You are quite right, but these are sciences. Try to connect them to a syndrome. It is heart failure and intoxication. Yes? You can suspect syndrome
Heart
of,
fail because of what?
sorry, respiratory failure. Respiratory failure.
Respiratory fail. Okay, thank you.
Yes. You can suspect syndrome of pulmonary induration. Yes, you can suspect it. Okay, so what investigations are necessary? Just one by one, and what are they for? Please try.
X-ray for the chest.
Which one? Common X-ray, indirect projection, yes? And if there are any abnormalities from one or both sides, it is necessary to perform sides projection, one or both. Good. What would you like to verify at X-ray? Which syndrome? The syndrome of pulmonary enduration, yes? So the focus is of pneumonia. What else? Colleagues, what other investigations are necessary to perform here?
ECG, I think.
ECG. It will be nice to have ECG. Okay, because we shall treat the patient, we need ECG. What else? If we are speaking about pneumonia, just switch on the protocol of pneumonia investigation. What is it? X-ray, then CBC, we are interested in leukocytes, deviation to the left, ESR level. What is the main parameter, biological parameter for pneumonia? Because it may be a bronchitis also. How can we differ them without X-ray? C-reactive protein is a marker for pneumonia of any type.
That is thickening of the wall.
Once again, what?
The difference between bronchitis and and pneumonia, thickening of the wall.
Yes, you will see it, but we are speaking about a variety of necessary investigations. For example, X-ray won't show you any pulmonary induration. It may be in case of viral pneumonia. What shall you do? And it will be signs of chronic bronchitis at X-ray with induration of bronchial wall. So you need C-reactive protein for verifying that it is pneumonia. Colleagues, just standard procedure for each syndrome. Write it down. We have done it for a lot of time. It is in each presentation. Just write it down. Pneumonia, X-ray, CBC, C-reactive protein. And give the details. What would you see at complete blood count, for example? You will be asked about it. Okay, let's go on. Case number 2. You have an opportunity to train. Imagine it is an exam. And try, please.
It's maybe pneumonia too.
You're quite right. And the same, yes, the same procedure for investigation. Yes, yes.
Doctor,
But
you told
yes,
in
you're
the
welcome.
first case, you told us we have a respiratory fail and pulmonary induration.
Yeah.
Okay, thank you.
And you can see it here without any doubts. You can.
So what is
yes,
doctor?
just a minute. I shall answer to the phone.
Okay.
Слушаю. What was your question?
Signs of pulmonary induration. What is it?
What are the signs of pulmonary induration in this clinical case? Because in this one, we can only suspect them. We have no results of direct exam. Here we can see the results of direct examination, and it is increased phrematous and bronchial breath in the right base, and there are crackles in this area. Crackles.
Okay.
These are the main signs of pulmonary induration, together with the syndrome of intoxication and respiratory failure. Why respiratory failure? Because of dyspnea. Why dyspnea? Because the number of breath movements is more than 18. And you can imagine that each pneumonia is accompanied with mild or more severe respiratory failure. It can't be without. Absolutely can't. So the same standard procedures, the same plan of investigations must be done. If it is estimated that damaged, the right lung is damaged, let's provide right side X-ray a direct one and right side.
And we can use CPC2, yes? CPC2, yes?
Complete blood count or
Yep.
computed tomography.
Complete blood count.
Complete blood count will be enriched leukocytes with left deviation in typical situation, ESR enlargement, maybe elements of anemia. That's all.
Okay, thank you.
Colleagues, any questions? We shall, we have enough time to train. Okay, let's go on. So please, the third clinical case. Do you have any
Pneumonia.
class? The third one, I suppose it's more close to bronchitis. Colleagues, do you have any other classes today?
No.
No?
Mhm.
Because honestly speaking, our class is over according to the timetable. But I decide to prolong it, and if anybody wants, it is possible to be out away of our class, and nobody will be punished. Don't worry. But I suppose that it's better to do maybe 10 clinical cases for you to understand what is necessary to do further with other. Okay? Okay? Okay. So, why it is not a pneumonia? Have a look.
Maybe because of wheezing
For
and
10
bronchitis.
for 10 years, just remember, pneumonia always is acute situation. It is an acute disease. Here we have 10 years disease with productive cough. It is bronchitis. Cough occurs during the whole day with sputum. And several times a year, she has exacerbations because sputum becomes purulent. And she requires antibiotics therapy. Yes, it is exacerbation. She doesn't smoke. Maybe there are some occupational harm factors. And at examination, we can auscultate wheezes and rhonchi, which are diffused. Diffuse, so inflammation like pneumonia of all fields of pulmonary tissue, we can't imagine. It is impossible. It is unconnected with life. So it is bronchitis without exacerbation because it is not declared that she has any fever, any green or red color of sputum. So it is a common bronchitis, chronic one, without exacerbation. What shall we do in investigations? First of all, we are interested whether the patient has respiratory failure. 10 years may formate respiratory failure. That's why we need in direct examination the number of breath movements. Then we are interested in her vital parameters, blood pressure, heart rate, because we ought to know about them. Maybe he is a hypertensive patient. She may be. And directly to chronic bronchitis, it is also necessary to perform X-ray, common X-ray, spirogram to see the obstructive components, because wheezes are very often associated with bronchial obstructive syndrome. We can suspect it here. And sputum test. We know about sputum test. It must be done to see the key elements of her chronic inflammation. It may be neutrophils if the main cause are bacterial inflammation. It may be allergic inflammation. In this case, it will be eosinophils. In case of neutrophils excess, it is necessary to perform cultural test to try to see the microorganism responsible for this chronic inflammation. And chemical test to verify the absence or the presence of atypical cells, which may be due to cancer, bronchial cancer. In case of appearance of atypical cells, computer tomography of the chest must be done. And this is the whole investigation in case of chronic bronchitis. Complete blood count I have mentioned, or maybe not. So any questions about this clinical case? No. The next, please. We have done it. We have done it, and it is not necessary to repeat, I suppose. Oh, no, we haven't do it. Sorry. Let's do it. So, colleagues, maybe somebody wants to give comments.
Lung abscess?
Why do you think so?
I don't know.
Now, let's
Smelling
analyze it.
sputum productive of putrid, so it says. And the crackles, the dull percussion, it suggests the abscess, lung abscess. And the elevation of blood urea may be damage from alcohol.
Urea in this case is together with crackles. Crackles, first of all. Crackles are formated in alveolus, demonstrate as pneumonia. And you're quite right. Putrid fluid smelling sputum may be associated with pulmonary abscess, very common in alcoholic persons with pneumonia as an exacerbation or as a complication of pneumonia. Better to say a complication of pneumonia. Moreover, we have the situation of bad dental hygiene. And the patient also has respiratory failure. And urea is not given here only due to his liver status. If we look at CURB scale, CURB, C, consciousness, Nothing is mentioned, so let it be normal, 0. Blood pressure, normal. But respiratory rate is more than 32, and urea is really enlarged in 3 times. So 2 points this patient has. What does it mean? That the duration of the pneumonia is moderate or severe, and he must hospitalized. Moreover, he has concomitant condition. Next step, we shall teach you that delirium is very often in such situations. That's why he must be under hospitalized observation. At this step, it is necessary to calculate curve scale to show your knowledges and to say that it is not mild duration of pneumonia. First of all, because of respiratory failure and of this level, 32 is rather severe dyspnea and intoxication. Blood level of urea indicates the level of intoxication. Is that clear? What investigations are necessary? X-ray, first of all, because we are to see where the abscess is. It may be done as CT for better visualization. Common blood count. Chest, chemical blood test to see liver function and liver inflammation because of his peculiarities in medical history, and maybe abdominal ultrasound to see the presence of portal hypertension of ascites or to exclude these conditions. Is it clear? And what are the main signs of intoxicative syndrome here? Fever, chills, urea. These are. Good. Let's discuss the 5th one. So, what would you suspect here?
Bronchial asthma.
You see, you may suspect bronchial asthma because of wheezing.
Yes, and because of he used accessory muscles.
Yes, you are quite right. At least if you say about acute bronchitis or exacerbation of chronic, you won't be wrong because inside bronchial asthma, we have bronchitis. And
Pneumonia.
and no pneumonia is here because we can't see the local abnormality. We can see it's diffuse. What is about 40 breaths per minute? How would you identify it? As which syndrome? And using of additional muscles. This is respiratory failure, colleagues. It is respiratory failure. And another syndrome is arterial hypertension. So what is necessary to be done? X-ray, common one, or according to the age and possible prolonged situation, computed tomography without contrasting. CBC, especially for leukocytes and eosinophils. Eosinophils must be done both in percentages and absolute amount. Sputum test, common one, and cultural. Also chemical sputum test, or sometimes it is named as cytological. Cytological is better. What else? Do we need, for example, spirometry here? No. How can you imagine spirometry at such dyspnea? No, we do not need. Saturation may be done by pulse oximeter. And ECG, hypertension, and maybe echocardiography to see the fraction of ejection and to see the right side of the heart. Because I suspect not only respiratory failure, but heart failure here, maybe. This is the plan of investigation. Any questions? Okay, what is here? Clinical case number 6, please. It is an emergency, acute situation.
Bronchial asthma?
Or obstructive bronchitis, acute obstructive bronchitis. Saturation must be measured by pulse oximeter. And X-ray, chest X-ray, direct projection. CBC, and C-reactive protein, the same as for previous clinical case. That will be enough here. As you can see, we can't perform spirogram. It will be done after recovery from the acute situation. Any questions, colleagues?
No, thank you.
Okay, the 7th, please.
Pneumothorax pneumonia.
Well, I suppose it is obstructive bronchitis because of the lung examination.
I'm not really special.
With mild respiratory failure. And it is very typical to heavy smokers. So according to these diagnoses or number of syndromes, the plan of investigation will be spirometry, chest X-ray, because of prolonged smoking history, computer tomography will be better to verify the peculiarities of emphysema. Spirogram with bronchodilatator test. If sputum production presents sputum test, both common and culture. Complete blood count, C-reactive protein. Spirogram, I have said. Questions? No, okay. Here we are. Clinical case number 8. So how to calculate the deficit of the pulse? 110 minus 85. It is 25 beatings per minute. It is a real pulse deficit, a significant one. So the main syndrome is arrhythmia. What must be done? First of all, ECG, computed tomography for the purpose to exclude the thromboembolism of pulmonary arteries. Natriuretic peptide, edema of legs, we can suspect heart failure. And complete blood count to exclude inflammation. Any questions, colleagues? Okay. 2 more clinical cases and we shall finish. Here we are, please. Have a look at the blood pressure level. Tendency to be low. ECG signs of arrhythmia. Moreover, we can estimate it. It is atrial fibrillation, irregular ventricle complexes, and absence of P waves. And edema of feet, low blood pressure, tachycardia. It is heart failure. So echocardiography must be done. Pro-BNP or BNP in blood as a marker of heart failure. Complete blood count and biochemical blood test. In biochemical blood test, common parameters of function of renal of kidneys and electrolytes like potassium. And the last one, please. What are the main syndromes here? Without any doubts, we can speak about arterial hypertension, and we can suspect heart failure. In this case, it is necessary to perform ECG, echocardiography, complete blood count, chemical blood count to verify the function of kidneys, urinary test for albumin in urine and full urinary test, and fundoscopy. 3 target organs must be verified. Daily monitoring of blood pressure will help us to estimate the degree, because now we can speak about the 3rd degree of arterial hypertension. Okay, colleagues, let's finish today's class. During this hour, I shall send you these clinical cases. And tomorrow we shall continue to discuss these clinical cases. Do you have any questions to me? No? Okay, thank you for your attention and your attendance. See you tomorrow. We shall start at 9:30 tomorrow. Thank you. Goodbye.
Thank you.
Up to you. I shall give you all the comments. So, in this clinical case, we can discuss 2 main syndromes. The first one is, without any doubts, arterial hypertension because of the enlargement of blood pressure. And the second is typical pain for acute coronary syndrome. We can suspect acute coronary syndrome due to typical retrosternal pain with irradiation. The patient must be investigated by the following plan. Though acute situation is due to coronary arterial disease, we start with ECG, troponin test, and all other markers of myocardial necrosis. They are myoglobin, creatine phosphokinase, MB fraction, it is myocardial fraction, and then echocardiography with chemical blood test, where liver and kidney parameters and the sugar level will be detected. We need the level of creatinine for calculating of GFR, because very often coronarography must be done both by diagnostic and treating purposes. Concerning arterial hypertension, we are to see the condition and function of target organs. I have already mentioned the kidney function with creatinine and calculating GFR. Then albuminuria, And we shall see, while performing echocardiography, we shall see hypertrophy of left ventricle and fundoscopy will be enough for evaluation of the condition and function of target organs. This is the answer to the 11th clinical case. Any questions, colleagues? Okay. Clinical case number 12. We can speak about gastroduodenitis with the prevalence of duodenitis and pancreatitis in this clinical case. Why is it so? Because of localization of the pain syndrome and because of the medical history with alcohol abuse. Moreover, the results of abdominal palpation. The prevalence of pancreatitis is without any doubt. In this case, it is necessary if bowel sounds are good, we can start with ultrasound investigation. Complete blood count to see the level of inflammation. Ultrasound investigation will give us the condition of abdominal cavity, excess gas, fluid, the sizes of organs, and their peculiarities. For example, damage of liver, of spleen, the diameter of portal vein. If it is possible, we can visualize pancreatic gland. If bowel sounds are decreased or absent, common direct X-ray. Examination of rectal zone with glove, just to see the presence or absence of melena, black stool. Biochemical blood test. The main parameters of liver and kidney function and amylase, the pancreatic enzyme, glucose, it will be suitable to perform upper endoscopy. Helicobacter test, and if there are any peculiarities in mucus, local biopsy of the damaged zone. We also can see lipase activity in the urine due to pancreatitis. In the complete blood count, we shall see not only the signs of acute inflammation, like leukocytosis and enlargement of ESR, but some other. For example, high level of MCV because of chronic alcoholism. And we are interested in parameters responsible for bleeding, hemoglobin and hematocrit, because such pain may also be according to peptic ulcer disease in duodenal zone or in epigastric or both. This is the answer to this clinical case. Questions, colleagues? No, okay. Clinical case number 13.
Also gastro, yeah.
Yes, you are quite right. We have done it yesterday. Gastroduodenitis. You are quite right. And the common plan of investigation with complete blood count, with urine test, by the way, just name it as a complex first step investigation if it is not of high level of emergency, like in acute coronary syndrome. It must be done because there may be some peculiarities which will give you another information, additional. So upper endoscopy with biopsy and with Helicobacter test. Complete chemical blood test, and stool test for verification, if it is possible, for verification of occult blood. Okay. Number 14, please. Dyspnea, I suppose. Yes. I suppose dyspnea is due to pain syndrome. We may suspect bleeding here. We may suspect it. Yes, because of low level of blood pressure. Which plan is more suitable here is upper endoscopy, complete blood count with verification of hemoglobin and hematocrit, and rectal inspection with glove to see whether if some elements of feces can be found. We can see the presence or absence of melena. Melena is a typical signs of upper gastroenterological bleeding. Yes, you're quite right that it is bleeding, and the source of it is more often, in this case, a duodenal ulcer, because of such appearance of epigastric pain. It is more typical to duodenal zone, though it may be a stomach also. Okay. What is about 15 test case? So it is coronary artery disease. If it is the first episode, we can speak about first episode of angina. If it is not the first episode, we can speak about angina at effort. Arterial hypertension, look at the level of blood pressure. And the heart failure, appearance of gallop rhythm. It is heart failure. What is necessary to do? In case of such situation, it is an emergency one. Cardiac enzymes or cardiac markers of myocardial necrosis must be done. Myoglobin, troponin, creatine phosphokinase, and bifraction, complete blood count, common biochemical test, and ECG, echocardiography, and the patient must be prepared for coronarography. While the patient is preparing to coronarography, we can see the function of kidneys with GFR calculation according to the creatinine level. Echocardiography will give us hypertrophy of myocard of the left ventricle. And if we are in time, we can perform fundoscopy. It is 1-2 minutes to see the vessels. Any questions, colleagues? No? Okay. So clinical case number 16. So this is the acute heart failure in the patient with medical history with hypertension and diabetes. So all the signs, dyspnea, low blood pressure, tachycardia. Moreover, she has angina attack. So it is acute heart failure due to angina attack also. Echocardiography and ECG must be done. Cardiac biomarkers, myoglobin, troponin, creatine phosphokinase, and bifraction. Biomarker of acute heart failure. It is brain natriuretic peptide, also must be done. Complete blood count, common urinary test. Chemical blood count. Echocardiography. ECG. This is the main. Colleagues, any questions? Okay. Case number 17. It is chronic heart failure with typical signs and hypertension if it is estimated. It is necessary to perform ECG, echocardiography. All the tests we have mentioned in the previous clinical case, but not of emergency block. First of all, we need brain natriuretic peptide. It is a marker for heart failure. It doesn't matter acute or chronic. If the compliance are not acute, they are chronic, it is not necessary to perform myocardial necrotic biomarkers like troponin. Just full chemical test after complete blood count. And if it is necessary, planned coronarography may be discussed. Results of the additional investigation will give us the information if it is necessary to perform coronarography. Clinical case number 18.
Acute myocardial infarction.
You're quite right. So we investigated according to the standard procedure, myocardial biomarkers of necrosis. Then echocardiography ECG is done. We just monitoring it. Full biochemical test. And the patient must be prepared for coronarography and thrombolysis. So we need the coagulogram or hemostasiogram. They are synonyms. Thrombolysis and stenting during coronarography may be performed one by one. That's why the patient must be prepared with corresponding investigations. Clinical case number 19. It is also acute myocardial infarction, hypertension. So the previous answer to the investigative plan may be used also here. Okay, and the last one, please, case number 20. I suppose clinical case is familiar for you. We have done like this a lot. So it is acute hepatitis. The main syndromes are inflammation, cytolysis, and cholestasis. It is necessary to perform abdominal ultrasound and to monitor all laboratory tests. That will be enough, but the monitoring must be each day. Okay, colleagues, we have discussed all clinical cases that you will get at exam. Now let me tell you the procedure of the attestation on Monday at the 28th of December. Group 76 will start at 9 a.m. by Moscow time. Group 77 at 10:20. You may not mark it, just listen. I shall send you the whole information. Group 78 at 12. And all groups for summary of the attestation are welcome to 1:45 by Moscow time. Each student will get 2 clinical cases, 10 minutes to be ready, and then answer. It will be necessary to switch on camera because the procedure will be according to the registration. It will be done in Zoom. I shall send you the links for Monday. and the time of the onset of each group. According to the geographic localization, group 76 will start because they have 5 hours plus from Moscow time, and the main students of other groups are not so far, so they will start in other hours. The whole collection of the students is not so necessary. This is the time for solving of the problems if somebody is not satisfied. And next day, I mean the 29th of December, the Department of Propedeutic will put all our marks to electronic examination lists. So you will see them, I suppose, before New Year. Which questions do you have to me? No questions? Okay. So, yes, no questions. Good. You're welcome. Without any doubts, each student will get additional questions according to the topics. Don't worry, it won't be nervous. It will be extremely soft and nice. Don't worry. The third year is very difficult in medical institutes. That's why